Karen, welcome, and I enjoyed chatting with you earlier this week in meeting. We had a fun chat, and we're actually going off script a little bit from the agenda. We're going to end up talking about ambient AI and privacy, and not bore people with CPT codes. So, I hope everybody is happy with that. But Karen, I think you and I both saw at Vive probably 25 plus vendors selling and or pitching some form of ambient AI, most targeting what was happening in the exam room between practitioner and patient. And and more recently, just in the last 10 days or so, the class organization came out and reported that 58% of all health systems are planning to roll out ambient AI in 2024, which kind of, given that while it's been worked on for a long time, it really hasn't become a thing until late 2023. I think arguably positions it as the fastest rollout of any IT we've ever seen in healthcare, potentially. So I wanted to get some thoughts from you about how you're, as an organization, beginning to think about ambient AI from a privacy point of view, and what are the top issues that are kind of on the table at this point in time.
Yeah, thanks, Don. I think that what you're beginning to hear about and what we're beginning to think about in terms of rollouts are things that might integrate with our electronic medical record system. So things such as listening in clinic visits so that physicians can spend much more time talking with our patients about what is actually happening and less time perhaps on documentation. And so in terms of the ambient AI, would be listening in the background, performing the documentation by the AI, increasing efficiencies for the physicians. Also things like meeting assistant tools, in Zoom or Teams, where the discussion can really take place and the meeting minutes can be taken by the AA assistant. And then in both of those cases, somebody would obviously be going back and reviewing the documentation to make sure, that there's data integrity and that it's correct. Other things that we might be thinking about would be hospital at home. So whether there's an opportunity for ambient AI to be in patient homes that we can leverage from a healthcare perspective, or even patient wearables. And so from a privacy standpoint, I don't know that it's really different than the way that we think about data privacy just generally. Privacy and chief privacy officers are always worried about trust, making sure that our patients and our consumers, using that word to those patients who have not yet received care from an organization, that there's just transparency around what we're doing so that they can feel that their data is being kept private and secure, they're receiving the correct care, but that there remains that level of trust that they've come to know and expect from us in healthcare.
Sure. Let's delve into a couple of the characteristics. I'm aware of at least one company, Quantum AI, that follows a structure or an architecture where they don't keep the recordings of the ambient AI. They just output the quote unquote the summation, the EHR entries and SOAP notes, etc. Whereas others actually do keep the recordings for any number of reasons, including, for example, the ability to share the interaction with, say, caregivers, for example. Mm-hmm. I'm wondering, as you think about the privacy issues, how do you think about, or how are you thinking about going about evaluating? Would we want to go down a path where we are keeping the recordings, or would we rather go one where we're not keeping the recordings? And from a medical liability and discovery point of view, how does that weigh in?
Yeah, that's a really good question. I mean, I think there's probably no good answer one way or the other, which is really how privacy officers hedge all of their answers, I think. But, I think it really depends on the purpose and the use cases. So I think, like everything privacy related, it always has to go back to what is the use case and what is the purpose for that data. And so because of that, I don't think there can be a one single strategy. I think that in healthcare, we need to look at what is the technology doing? How are we going to use it right now? So if the only purpose is to use it right now to assist, for example, with documentation and efficiencies for the provider-patient interaction, then there may not be any reason to keep it any longer than as the time that the physician has to go back and make sure that the data is correct, the note is written correctly, that that it all makes sense, and then it's pushed to the actual medical record. However, in larger academic medical institutions, they might want to keep certain recordings, for example, for research purposes, to be able to train AI models to do bigger and better things over time. And that, again, doesn't mean that it's every AI tool that we do that with. It has to be very deliberate, and the contracting for the tool has to spell out those types of things. So if we want a vendor to delete the data right away, it has to be done in a compliant manner. So all of those things need to, I think, be accounted for. Your other question had to do with medical liability, which isn't really my area of expertise, but yes, the answer is yes to that. It does create some additional risk for the organization the longer that those recordings are kept.
I got a different question, again, in this case, related to hardware and perceptions of privacy. Some of the systems that are out there are basically built around using the phone. So that suggests a use case where the doctor walks in the room with the patient and throws their phone out on the table and says, we're going to have a conversation. I've actually done a little informal poll of about a dozen folks, and they all find that rather intimidating. So that seems like potentially a bad hardware use case. Another use case is using the microphone that's already built into the computer. That seems like that's not going to work very well because those are directional mics. And I think that's going to be problematic, is my guess. A third option would be using a omnidirectional microsystem, more along the lines of an Alexa or something like that in the room, or maybe in the ceiling. And I'm just wondering, how would you go about thinking of that from the patient's perspective of privacy in terms of hardware selection? But even more importantly, at least two of the people I interviewed raised the question that says, I've actually asked the doctor if I could record the session, and the doctor said no. Now the tables are reversing on the doctors, and so it's an interesting twist on the privacy question.
I think that's a fair point on the patients. I think most of the time, recording is not something that's typically allowed. However, this is changing the table, so I think that's a very fair point. I think it really starts, again, these things always start in my mind with engaging with your privacy professional at your institution early on. So before you even contract something, that you have a discussion, several discussions actually, about what does this look like as you roll this out. And then you can begin to think about, Dawn, all of those things related to, the buzzwords these days, privacy and security by design, and all of the technical specifications. I really like the idea of this idea of trust and transparency. So how are we informing patients, usually both in writing and before they get to the room, about what we're trying to do here? And so that could involve a number of things. That could involve mass communication in advance, that the organization is about to roll out something similar to this, and here is how we're thinking about it as a health system. But letting them know and letting them have the ability to say yes or no, I think, is very key. But it also means explaining it to patients in a way that they understand, which is usually somewhere around a 5th grade level. And so I think that's really important for us, is to get that buy-in early on. In terms of the use of actual technologies, I think that really just depends on the system itself and how it's set up. You're trying at this point, right, to increase efficiency and time, and roll things out, as you said, fairly quickly. So if you have to change your entire infrastructure for this, I'm not sure that that really meets the efficiency scales.
Doesn't that work both ways? You can imagine the AI being applied to the answer to questions. Is the nurse in the room or the MA in the room doing their job correctly or completely? Is the doctor doing their job correctly and completely? So in other words, it may not be entirely about the patient's privacy. It may actually be about the employee and or the professional privacy as well, in terms of their concept of privacy, as opposed to, say, medical appropriateness, completeness, and just an organizational efficiency application.
I think that's right. And I think we focused a lot, yes, the discussion a lot around patients, but yes, those types of transparency and trust and consent documents apply to employees as well.
Yeah, I would think so. I think what I've observed is a lot of physicians are jumping up and down saying, yeah, bring on the ambient AI. I want that time back. They haven't really thought through all the downstream consequences of where this is likely to lead. I think most of it's going to be good in the terms of helping them practice better, more completely, etc. But it can actually start turning into even an HR application. One application I've recently read is ambient AI in the OR, which is really analyzing how the team is interacting together. Going towards, I mean, the aspically to look at OR efficiency, but you could also imagine it finding some poor practices as well.
No, I think that's right. I think, one thing to think about too, especially in the OR, is this concept of teams, right? And so who are the best teams that work together? So are there employees who work best, or staff that work best with certain other employees or other physicians? And, what do those teams look like in terms of OR scheduling, and how can that also be looked at? And so I think that goes back to this issue where we were talking about how long should recordings be held, right? Because those might be the kinds of reasons you might want to keep certain types of recordings for quality improvement or research purposes.
One of the potentially controversial areas that we may see use pop up, but it actually may have some very strong benefits as well, is the notion that companies in the pharmaceutical industry, the medical device industry, who've never had a presence in the exam room would like to have at least a summation of what goes on. How are their products, services, therapeutics, diagnostics presented? How are the patient reactions to those? Obviously leading to changes in maybe marketing and advertising campaigns, but also potentially into product changes as well over time. But that's an interest that we've already seen expressed, is other parties, third parties' interest in what's going on behind those closed doors. How do you kind of think, how are you going to be thinking about that?
Yeah, I mean, so you're asking a privacy officer. So for my first response to that is, those are the types of things that I like to limit in an organization, right? I mean, especially because sometimes that's very sensitive information that's being asked for. And so when it's possible to limit or minimize the amount of data that might be available to a third party for some other reason, or even to your own marketing teams, those kinds of things need to be thought of in advance, how it can actually be used. And you also need to be able to tell your patients in things like, for example, your notice of privacy practices, how data could be used. And this is just one other form of regulated data. And so it needs to follow those same parameters. I'm not saying that it's always a no. I mean, we want to try to get to yes, because we all want to be able to help patients, and things that can do that are important.
I think we can both come up with a long list of things that are both positive and negative about that situation. One of the practical things is your CFO may be saying yes, but if we allow that in, the system's going to be cost less or be free, and as a result, that could have huge economic consequences as well. So I have one last question as we come up to you, and it's a little bit tongue in cheek, but it's very topical today, and that is, how much do you think Kate Middleton's or Joe Biden's ambient AI conversation is worth?
Oh, wow. I don't know. That's a good question. So I have to choose between the two.
Well, I don't know. You can take it any way
Oh,
you want,
I
but
think it's both pretty bad, I would say. I think, but I think that one thing as a privacy officer also to say is that I'm not exactly convinced that one patient's information is more important than another. They just seem to be more high profile and known.
I think the Daily Mail might actually be willing to put a price tag on at least to Kate's
Oh,
sake.
sure, that's true. I'm sure that's true.
Well, thank you very, very much, Karen. I enjoyed meeting you earlier this week, and thank you for engaging me on how privacy officers are thinking about ambient AI.
Very good. Thank you so much for having me. Pleasure.